Today we've got three separate sessions or presentations, and we've got 5 different speakers that are participating in this. I'm going to go ahead and just go through the bios of our speakers, and then we'll be able to get started with this presentation. The first presentation is Perceived Efficacy in Patient-Provider Interactions in RHCs and FQHCs in North Dakota. And the presenter is Claire Erickson, who is a first-year medical student at UND School of Medicine. She graduated from UND in 2019 with a Bachelor of Science in Public Health Education. For her senior thesis, she partnered with the Center for Rural Health, which resulted in the presentation today. She recently completed a certificate in American Indian Public Health from NDSU and is working on an MPH in Health Management and Policy from UND. Her goal is to increase access to care and health equity in the Midwest. Claire is currently employed by the North Dakota Department of Health. The second presentation we'll have is a low-cost and effective tool to improve a community's substance use disorder care preparedness. And the presenters we have for that is Margarita Quinci. Margarita Quinci is a third-year medical student from Grand Forks, North Dakota. And the other presenter for that is Quinci Paine, and Quinci is a fourth-year medical student going into OBGYN with an interest in rural health. The third presentation we have will be on Geriatric Tele-health assessment project. And the presenters for that are Melissa Marx, who is a BSN RN CHSE, graduated from the University of North Dakota with her bachelor's degree in nursing and her health administration certificate from Master of Public Administration. Her business degree was obtained from Northern State University. She anticipates graduating from UND with a MS degree in nurse education in May of 2021. She has been the simulation manager of the Clinical Simulation and Resource Center at the College of Nursing and Professional Disciplines since 2003. Her nursing practice includes public health nursing, home care nursing, nursing education, and the interprofessional simulation education. The second presenter with this topic is Melissa Koehl. Melissa obtained her Bachelor of Science in Nursing from the University of North Dakota in 2010. She worked as an RN at Lake Region Healthcare in Fergus Falls, Minnesota. In May 2020, she graduated from UND with her master's in adult gerontology, primary care nurse practitioner degree. She is certified as an adult gerontology, primary care nurse practitioner. She continues working for Lake Region Healthcare as an AGNP. In May 2020, she graduated from UND with her master's, and in August 21, she will graduate with her Doctor of Nursing practice degree from the University of North Dakota. All of our presenters have indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and/or investigational uses of product or services and will not include trade names. So with that, we'll turn it over to, I believe that we're going to have Claire starting us out.
All right, I'm just going to do 8 minutes to keep it really short here. As Mark said, my name is Claire Erickson, and this presentation is actually on my undergraduate thesis. It was supposed to be presented last year, but we did not have the conference, so I'm excited to get over my thesis. But it's Perceived Efficacy in Patient-Provider Interactions in 2 rural health clinics and a federally qualified healthcare center in northeastern North Dakota. So this is my poster. I thought I would do a presentation just provided the platform we're on here. It's available on my LinkedIn, and if you would like a PDF of it or something like that, my email is in my profile. I would just like to start by acknowledging the Ojibwe and Oyate peoples, as well as MHA Nation that North Dakota currently sits on. And we'll get started here. So my motivation for my undergraduate thesis is that I began to be interested in rural health during my time at the National Rural Health Association in Washington, D.C. I learned a lot about rural health policy, and particularly how important the Center for Medicare and Medicaid Services are to rural clinics, and learned about different clinic structures such as federally qualified health clinics and rural health clinics. And I just wanted to get my foot in the door and see if I'd want to work there. So I decided to team up with a couple clinics through Lynette Dixon at the Center for Rural Health and see if they'd be interested in my other passion, which is patient empowerment and patient efficacy. Efficacy is one's confidence or ability in their ability to do something. In this case, it's going to be speaking with their provider. So just a really big zoom out. Rural health inequities, if you're attending this conference, you're probably aware of them, but we usually say rural individuals are older, sicker, and poorer. And currently there's healthcare workforce shortage. 57% of health professional shortage areas are in rural areas, which are considered underserved. There's been a slew of critical access hospital and rural clinic closures in the past couple decades, and the AAMC projects a physician shortage, and there's projections of nursing shortages and all different types of provider shortages, which will especially hit those rural or underserved areas. As I said before, clinic structures such as rural health clinics, federally qualified health centers, and they receive advanced reimbursement from the Centers for Medicare and Medicaid Services, and their populations are more likely to be insured by CMS via Medicare and Medicaid. So Medicare and Medicaid make a huge, huge difference to these clinics. And currently there's 51 rural health clinics in North Dakota and 22 federally qualified health centers in North Dakota. Rural RHC or rural health clinic is for rural specific, and FQHC is technically for low income or underserved. The quality payment program is how CMS reimburses or pays physicians and clinics. And in 2017, they moved from a fee for service to quality outcomes. And in which case, two that are really important are the patient outcome and the patient engagement experience. And these are important because studies have shown that higher patient efficacy leads to better patient outcomes, higher patient satisfaction, and patients are more likely to adhere to treatment and medications. So this is the big zoom out. And my ultimate hypothesis was that higher patient efficacy leads to higher QPP scores, which leads to advanced reimbursement from CMS and keeps those clinic doors open, and it's cyclical. So I decided on a scale called Perceived Efficacy and Patient-Provider Interactions. It's 10 questions on a 5-point Likert scale, 50 indicating a high level of confidence and 10 indicating low. It has a strong internal validity in many different populations, which is why I chose it. And the questions all center on that patient confidence. So how confident is that patient to understand what their provider tells them, to get all their questions answered, to ask questions about their chief health concern. And I made it into a Qualtrics survey, and following IRB approval, I sat in clinic lobbies and asked them either out loud if they wanted to, or they could go through it themselves on an iPad in the clinic lobby, and data was analyzed via SPSS. My locations were Northwood, Pembina, and the FQHC here in Grand Forks, so 2 rural locations and 1 federally qualified health clinic. The total sample was 101. Individuals, 42% were Medicare beneficiaries, 50% were over the age of 55, which again goes right hand in hand with those rural demographics. 56% were female and 43% identified as male, which makes sense because women are more likely to seek care. 84% identified as white, 10% identified as American Indian Alaska Native, and anecdotally 10% identified as Icelandic and Norwegian, which makes a ton of sense provided our current location. And my results were really interesting to me. I didn't find any statistically significant difference, but that actually is really exciting to me because the first score is for Medicare beneficiaries, and there was like absolutely no difference between Medicare beneficiaries and non-beneficiaries, which is super important going back to that reimbursement and to how much rural clinics and FQHCs rely on CMS. There was no difference between rural and urban, which is really good to see in here. There was a difference between female and male. It's important to note that the majority of providers were female, and studies have shown that one is more comfortable speaking to their provider if they're of the same gender identity. So that made sense. And another thing that made sense was that those with higher levels of education had higher efficacy. And we know this via studies and just learning about health literacy and different things like that. But the most exciting thing to me was that the majority of the providers were advanced practice providers or physician's assistants, nurse practitioners, what those fall under, formerly known as mid-levels. And I found that advanced practice providers or APPs actually had higher levels of perceived efficacy. So patients seeing these physicians had higher levels of efficacy than seeing a physician. However, it's super minute, super tiny, and not statistically significant. Don't let the graph fool you. But this is important because this lack of statistically significant difference could mean that the provider shortage in rural areas with clinics relying on higher APPs, they don't need to worry about losing reimbursement and may even have higher reimbursement. This study showed that patients feel no different, if not more confident, speaking to APPs versus physicians. This could be an argument for APPs to practice at the top of their scope of practice, which are the maps seen on the right. And it could lead to advanced reimbursement for utilizing both MDDO and APPs. So usually a CRH or a rural health structure might have like 4 NPs, 2 PAs, and then a physician that acts as a CMO or something like that. So this structure can work absolutely. Lots of considerations. It's just undergraduate thesis, so I wasn't actually examining financial reimbursement of these clinics. I wasn't comparing these clinics, and I wasn't looking at actual patient outcomes and patient data because it was only an undergraduate thesis. It was a small sample size, it was homogeneous, super tight data, and it was a convenient sample. So these are all things to keep in mind, but it was a great way for me to dip my toe in the water and learn about different clinic structures. And any questions at all? If not, we can keep going.
All right, so yep, sorry we didn't make a PowerPoint presentation, but if you guys just want to make your screen bigger to the full-size screen, then you should be able to see the poster a little better. But so we'll get started. I'm Margarita, a third-year med student with Quinci, Paine, recently graduated from UND Med School. Going to OB residency, and we are going to present our low cost and effective tool to improve the community substance use disorder care preparedness. So why we did this presentation is because substance use disorders and the opioid crisis are an ongoing public health problem in North Dakota. Solutions to promote nationwide to help combat this problem have been difficult to implement in predominantly rural areas, complicated by geographical, technological, and staffing challenges. So in a paradigm shift, we used the article produced by Green et al. Focusing on existing resources to combat this crisis, called the Calculating for an Adequate Systems Tool, or CAS, in 2017. We completed the study in 2019 using this CAS tool on a reportedly successful community, Counter County in North Dakota, to quantify the strengths and weaknesses of substance use disorder crisis response.
But this is a very complicated tool, unfortunately. And it's complicated because there's a lot of inner working parts. It's not difficult to use itself. But I'm going to do my best to try to explain the methods to you. So this tool is based on the 4 SAMHSA continuum of care categories. So SAMHSA is Substance Abuse and Mental Health Service Administration. And then the continuum of care categories were recovery, prevention, promotion, and treatment. And then the tool added a 5th category called referral. These 5 categories were then broken down into 32 components. You can see in a couple of our tables if you make your screen a little larger. Basically, estimated needs for each of these 32 components were then identified. And these were identified using region and community characteristics that we had basically found through using data sources like the Census Bureau. These estimated needs were then compared to what we knew to be the existing resources, and so it is able to highlight over and underutilized areas kind of within the tool. And so basically then it also identified these region characteristics, and that contribute to a global county risk score for hospitalization due to a substance use disorder. This is then compared to the national median. So there's almost kind of 2 parts to this project, kind of one showing what the risk of hospitalization is, and then the other kind of demonstrating areas that are over and underutilized. So the CAS and its workbook are freely available, very practical, easy to get your hands on. For the sources of information that we use a lot of national databases. So census data, North Dakota usage rates, for things like alcohol use. We also spent a lot of time talking to key community leaders. And so I think, for a small rural area, there's not always this national database on these tiny places. So having those community leaders was very important. We spoke with somebody at Public Health and someone at Heartview as well. We also did have to construct a few proxies with the help of the tool's author. An example of one of those proxies, because there is no formal record of alcohol outlet density for North Dakota, the time that we were doing this project, we made a proxy, which essentially we looked at the number of establishments with liquor licenses and then kind of compared them to the overall number of establishments within the area. So we kind of had to get a little creative and work with the tool's author to kind of figure out good ways to have it practically applied to rural situations.
So for our results, we found that the CAS tool calculated a global risk score of hospitalization due to drug or alcohol use with a score of 13. So this put it at the medium range, corresponding to a 0 to 25% increase in the hospitalization rate compared to the national median. And this, again, like Quincy said, was based on certain county characteristics that we had also calculated that contributed to this risk. The biggest contributors to this actually were the alcohol outlet density, rurality, and percent population male. And then certain components of the categories of care that exceeded the estimated need were the promotion category and prevention categories. So specifically, the amount of media-based advocacy events or marketing advertisements. If you look at the table here, you can see kind of what Quincy was describing. So you have the different columns. Observed community totals are the number of events or advertisements, for example, that we were able to collect from the community. And then the adjusted community need is based on what the tool itself estimates is at least the minimum necessary for the community itself. And then the estimated need column is how much they might have exceeded or been below that minimum estimated need. So for example, marketing advertisements, we found 104 community observations. They need maybe about 12, and then so their estimated need was 92 events exceeding the very minimum that they would need in terms of promoting anti-alcohol or drug use specifically. And then the prevention category, they also did well. The number of community-based programs, housing vouchers, needle exchange programs, and prescription drug disposal events and locations.
So some of the results that identified components of the care that did not meet the estimated need. So in the referral category, mental health training for police, which is defined as police officers serving a community who have received additional education and training on how to recognize and respond to mental health needs. So the estimated need is still 0 according to our table. However, it is something that was identified by the community members as an area that definitely needed improvement. I think kind of with the current political climate and everything, it is also applicable. It was also noted in the recovery category that transportation vouchers were an area of improvement. So this is defined as the number of vouchers provided within a year to assist those seeking treatment. I do believe that these are offered pretty regularly by Heartview. However, it was brought up to us that there is an issue with if you qualify for a transportation voucher due to your insurance coverage, you may not be able to receive services at Heartview. So it is available, but likely underutilized. And, you know, I think a big thing that contributes to this is the location and the rurality of town or county itself. And if you note in our table, it's a significant need of, you know, they need 60 more to kind of get that minimum need. So another thing that they noted too, I think it's a need of 1 is a parenting class for those with substance use disorders. I believe that there may have been some parenting classes offered at one point in the area, but it sounds like they were no longer offering them and they were no longer utilized.
Okay, so in conclusion, using this CAS tool, its handbook, and most of the required data are freely available online. Those databases, like the national databases, you can search for that online. And this tool is kind of handy in that it helps to identify needed or redundant resources to help optimize resource allocation for these smaller communities. It also appears that town or county itself is doing relatively well in terms of promotion and treatment categories. And using this tool may help to reduce hospitalization rates and improve community substance use disorder care outcomes.
So some limitations to our study. So one of the big things is that we had to develop these proxies due to the lack of available data in rural counties. So the particular one is the alcohol outlet density, which I mentioned earlier, that significantly increases Towner County's risk score. So something to keep in mind. There is sometimes difficulty obtaining appropriate, accurate data sources. The handbook that accompanied this table or this tool gave us a lot of good references to start, but just because Towner County is a small rural county, sometimes it was hard to find the necessary information. So it was really important to contact those key community leaders, and I realized that that might not be feasible in a larger study or in a different area. It was also brought up too by a lot of these community leaders that Towner County services are used by patients from other counties and vice versa, so that potentially affects the data. It also is to be noted that Towner County does have a substance use treatment disorder treatment facility, Heartview, and that's not always something that is available, more accessible for a small rural county. So I think we could do a lot with this kind of project in the future. We could apply this CAS system to other rural counties and then kind of compare what it looks like between Towner County and other counties and maybe help refine some of these proxies.
Okay, my name is Melissa Marx, and I'm a nurse educator student, and we have 3 other DNP students that did this project with us, and I'll let Melissa go ahead and introduce herself and start.
My name is Koehl. I'm working on this project. Unfortunately, we were students through Dr. J. Geriatric, through the UND School of Medicine. He was given the project through the Geriatric Workforce Enhancement Program, and this is based on a grant. So the goal is to bring telehealth programs to geriatric elderly patients out in a rural area community. Obviously, with COVID kind of happening, everybody was really limited to their providers kind of getting out safely. So that was kind of the goal of this grant, is to bring healthcare to the patients that necessarily able to safely get out. So what we did was we actually created an assessment tool based on the 4 M's, mobility, mentation, medication, and what matters most. And hopefully within the next couple weeks, we'll actually be able to implement our IRB approval, thankfully, after many, many months. But anyway, what we will be conducting telehealth assessments to the elderly out at the reservation in the rural North Dakota area. The participants will be in their home. We will be on our side. The participants are ages 60 years and older, chronic medical conditions, living in their homes and receiving home care through a quality service provider agency or QSP agency. We are using a mixed method study design, focusing on a mixed method in the fact that we'll be utilizing a pre and post test survey, using a Likert scale to see how well the telehealth assessment experience went for them. And we'll base, our pre-survey scores and our post-survey scores, but then the qualitative information will be what become programs, including what matters most is kind of based on, obviously, what matters most to them, including family, health, kind of overall everything. So the interventions, Missy Marx really stepped in and helped training these telehealth ambassadors on conducting the home-based telehealth services, what it is, how we're going to conduct these assessments. We will then administer a pre-survey questionnaire asking if they've had any experience with telehealth prior, or just kind of technology in general. Then we will conduct a modified wellness exam based on the 4 M's that the tool we've created, which focusing on medication, we'll review Beer's criteria to see if there's any interactions or different medications that would be best fit for them. With mobility, we will be doing the timed get up and go test. If they have some high fall risk mobility issues, we do have more of a stationary tool that we'd like to use for to do the mini cog assessment and then the patient health questionnaire too, to kind of see if there's any signs of depression or and then what matters most, we have a tool that we created. It kind of focuses more on their ADLs and their IADLs to see how well they can do those things and whatnot. So we'll administer that. After we complete it, then we'll give them a pre-survey, post-survey questionnaire, which will then ask them how their experience went, if they would do it again, those sort of things. Hopefully time will allow us and we will be able to conduct a second telehealth visit, kind of focus more on our findings, kind of some interventions that they could reach out and talk to their primary providers about, and maybe even do some further testing, time willing and patient willing as well. To the Geriatric Workforce Enhancement Program grant team, which includes quite a few people. Missy Marx will talk about that next. So it's kind of fun. I'll turn it over to Missy.
So we worked with a lot of collaboration with Dakota Geriatrics, the nurse practitioners, the physicians, occupational therapy, physical therapy, pharmacy, nurse educator, the reservation, home care agency. A lot of this collaboration kind of was done quite a bit in the fall of last year. And then we also put together the assessment piece that Melissa had mentioned, where it was time consuming on determining what could be asked with the telehealth visit, because what we want to do is make sure that the individual is going to be comfortable. We don't want them to think that we're going to try to take them out of their home. We want them to stay in their home, and that's what the telehealth assessment would be project is for, is to be able to give them that outlet with the assistance of a caregiver. We're very fortunate to have a caregiver that is able to go into the home and work with the elder or individual in their home and be able to guide them through it. We have done some training with the caregivers or quality service providers, and that it's just going to take a little bit of time, and we plan to be rolling here within a short amount of time with the actual clients in their home. It's a little different type of a telehealth visit, meaning that the caregiver is kind of the guide and making sure that the client is the centered care. We want to make sure that the client feels as if they're doing a visit at home that would be the same as if they were at the provider's office. And this is actually one of the benefits of rural North Dakota, is because we have bad weather, we have floods, we have a lot of barriers that could prevent somebody getting to the visit, but we also have the pandemic recently that also put this as a large contributor. And actually, when I did my needs assessment, considering this project back in June of 2020, the needs assessment was the fact that access to healthcare, and that was prior to actual COVID. So of course that is another contributor as well. And then what we have also some barriers with our project is willing participants. Not everybody was always up and willing to do this. I found that was kind of surprising to some. Myself, I wasn't surprised. I have home care clients and not everybody is on board for telehealth. So that was one of the things that was a barrier for us to get started, as well as the pandemic going on. Telehealth policy and coverage and implications. Not everything is available as easily in the rural area with telehealth. We have limited access to high-speed internet, especially out in the rural areas of North Dakota. It might be that we, in our case, we're providing an iPad that has the data service connected, but that is still not going to be a guarantee that service is going to work well. And then the limited access to electronic device, that would be the iPad that we're using. So we're providing the computer for this client as well as the caregiver. And that also, we're hoping that will kind of spark and be able to keep connection down the road, maybe more availability for the clients in their home. And this transportation, we're also having to have the caregiver go to the home. And so that's also been a barrier for the project. So what we're really trying to do is promote the use of telehealth with a positive impact. We want to make sure that the client does not have a negative impact in regards to telehealth. We want them to feel comfortable. The picture here actually happens to be my mom with one of our DNP students. And she actually is one of those that at one point wasn't overly excited about telehealth, but believe it or not, she has really kind of gained to appreciate the opportunities, especially with all the COVID in the past year. And we want to make sure that we're providing adequate training, not only for the clients, but for the caregivers, so they can feel comfortable with the clients in their home to provide them that support. And hoping opportunities for promoting telehealth areas in the near future. I know there's a lot of opportunities out there, and we hope to be part of that. Maintaining licensing and legal requirements. I know some of the reimbursements for telehealth has always been a concern as well. Is there any questions in regards to providing geriatric telehealth in the rural communities at all? Missy, is there anything else that you'd like to share?
Oh, I think we're very excited to get going and see how well this works. So thanks for taking the time to zoom in and tag along. To be continued.